Statins, one of the most commonly prescribed drugs in the world. But here's the catch. Why do some patients develop muscle pain, weakness, even myopathy? And what does coenzyme Q10 have to do with this? Hi everyone, welcome back to our channel. Today we are breaking down the molecular story behind statins and muscle toxicity in a way that actually makes sense. If you are preparing for NEET or MBBS exams, this is something you cannot afford to miss. So, let's dive in. So, how exactly do statins work? It all comes down to one critical step in cholesterol synthesis, the rate limiting enzyme HMG-CoA reductase. Think of this enzyme as a gatekeeper. Statins basically come and say, stop right there. By inhibiting the HMG-CoA reductase, statins shut down the hepatic cholesterol production at its source. Now, clinically, this translates into something huge. Lower LDL levels reduce risk of cardiovascular diseases. That's why drugs like atorvastatin, rosuvastatin, and simvastatin are so widely used in practice. But here's where things get interesting. Blocking their pathway does not just affect cholesterol, it also impacts other important molecules, and that's where side effects begin. Let's explore that next. Now, this is where the things get really interesting. Let's zoom into the mevalonate pathway, the core biochemical route for cholesterol synthesis. Statins block the pathway right here at HMG-CoA reductase, and this creates a metabolic bottleneck. Upstream, everything slows down. Downstream, multiple products get affected. Yes, cholesterol drops, that's the goal. But here's the catch. The same pathway also produces coenzyme Q10 and other isoprenoids molecules that are absolutely critical for cellular energy. So, when you block HMG-CoA, you are not just reducing the cholesterol, you are also starving cells of coenzyme Q10. And that's the key connection to what we see clinically, especially in the muscle tissue. Now, let's talk about coenzyme Q10 and why it's such a big deal. Think of coenzyme Q10 as a key player inside the cell's power plant, the mitochondria. It acts as an electron shuttle moving energy through the electron transport chain, helping generate the ATP, the energy currency of the cell. But that's not all. Coenzyme Q10 also works as a powerful antioxidant, protecting the cells from oxidative damage and stabilizing the membranes. And here's the clinical link. It's found in the high concentration in the muscle tissues, especially cardiac and skeletal muscle. And so the energy demand is massive. So if the Q10 levels drop, energy production suffers and muscles are among the first to feel it. Now you can probably see where this is going. Now let's connect everything into one pathophysiological cascade. It starts with statins, which inhibit the HMG-CoA reductase, leading to a drop in mevalonate, and that means reduced coenzyme Q10 synthesis. Now, here's the problem. Without coenzyme Q10, the mitochondrial electron transport chain begins to fail. Less ATP, more reactive oxygen species, and ultimately muscle cell damage. Clinically, this is what we see as statin-induced myopathy, and it does not stop there. Damaged muscle releases creatine phosphokinase (CPK) into the blood. In severe cases, myoglobin is released, which can lead to myoglobinuria and acute kidney injury. So, what started as a cholesterol lowering strategy can, in some patients, trigger a cascade affecting muscle and kidney function. Now, the big question is, can we prevent or manage this? Statin induced muscle toxicity does not present the same way in every patient. It exists along a clinical spectrum. At the mildest end, we have myalgia, just pain with normal CPK levels. This is actually the most common presentation. Next come myositis. Now you have pain plus a rise in CPK, typically more than 10 times the upper limit. At this stage, stopping the drug is necessary. Moving further, we can reach rhabdomyolysis, a serious condition with massive CPK elevation, myoglobin release, and a real risk of acute kidney injury. It's rare but potentially fatal. And finally, the most severe and unique form, IMNM, or immune mediated necrotizing myopathy. This one is tricky. It's driven by anti HMG CoA reductase antibodies, and importantly, it can persist even after stopping statins. These patients often require immunosuppressive therapy like steroids or IVIG. So, from simple muscle pain to life threatening disease, understanding this spectrum is absolutely clinical in clinical practice. Now, let's talk about what increases the risk. Now, let's talk about who is at risk because not every patient on statins develops myopathy. First, the patient related risk factors. Elderly patients, especially above 65, are more vulnerable. Conditions like hypothyroidism lowers the baseline coenzyme Q10 levels, making muscles more susceptible. And to that, renal or hepatic impairment, diabetes, and even genetic factors like polymorphism and risk goes up significantly. Now coming to the drug related factors, high potency statins like rosuvastatin and atorvastatin carry a higher risk compared to the simvastatin. But here's the real danger, drug interactions. Medications that inhibit the CYP3A4 like erythromycin, azole, antifungals, amiodarone, even grapefruit juice can increase the statin's level and push patients toward toxicity. And here's your NEAT PG poll. Don't miss that. Gemfibrozil plus statins is the highest risk of rhabdomyolysis. This combination should be avoided. So, identifying these risk factors early can literally prevent life-threatening complications. So, you have a patient on statins and they come in with muscle symptoms. What do you do next? Step 1. Don't guess. Check the serum CPK. Now, based on the CPK levels, your management changes. If the CPK is normal, this is likely myalgia and consider adding coenzyme Q10 supplementation. If the CPK is 3 to 10 times the upper limit, this is myositis. Now you need to reduce the dose or switch the statin and monitor the CPK levels closely. Also, don't forget to rule out hypothyroidism. But if the CPK level is more than 10 times normal or you suspect rhabdomyolysis, this is an emergency. Stop the statin immediately, start IV fluids, and monitor the renal complications and myoglobinuria. And here's an important clinical rule. Always rule out hypothyroidism before blaming statins alone. This stepwise approach helps you act quickly, safely, and effectively in renal practice. Now comes the big question. Should we give coenzymes Q10 supplementation to patients on statins? The theory sounds perfect. Statins reduced MEVALONATE, which lowers the coenzyme Q10, leading to the mitochondrial dysfunction. So, logically, supplementing the coenzyme Q10 should restore the energy production and improve the symptoms. But what does the clinical evidence say? It's mixed. Some randomized trials show modest benefit in myalgia, while others show no significant effect. And importantly, there are no strong guideline recommendations yet. Typical doses used in studies range from 100 to 200 mg per day. So here's the exam perspective. This is the key. Focus on mechanism of coenzyme Q10 depletion through the shared pathway. Don't overemphasize prescribing it. because its clinical utility is still debated. It's biologically plausible but not definitively proven. Let's bring it all together with a quick visual memory map. Think of statins and remember statins, Statins. S for skeletal muscle, myopathy and myositis. T for teratogenicity, absolutely contraindicated in pregnancy. A for ALT and AST elevation, so keep an eye on liver enzymes. T for drug interactions, especially CYP3A4 inhibitors. I for avoidance in active liver diseases. N never combine with gemfibrozil, risk of rhabdomyolysis, and S for severe complications including the rhabdomyolysis. And don't forget the core mechanism, coenzyme Q10 depletion leading to mitochondrial dysfunction and muscle injury. If you remember this framework, you won't just answer the MCQs, you will think like a clinician. Let's do a quick revision of statin showdown. This is a pure exam gold. Starting with its potency, rosuvastatin is the most important and potent, followed by atorvastatin, then simvastatin, and finally pravastatin as the least potent. Looking at half-life, rosuvastatin again stands out with the longest duration, while simvastatin and pravastatin are much shorter acting. Now, a very important differential, CYP3A4 metabolism. Atorvastatin and simvastatin are heavily metabolized by CYP3A4, which means higher risk of drug interactions. Rosuvastatin has minimal involvement and pravastatin has none, making it safer choice in patients on multiple drugs. Coming to myopathy risk, simvastatin, especially at higher doses, carries a higher risk, while rosuvastatin and pravastatin are relatively safer. And of course, all statins are contraindicated in pregnancy. Now, here's quick clinical takeaway. Pravastatin is preferred in liver disease and rosuvastatin is your safest potent option when drug interactions are a concern. Now, let's shift from theory to real world prescribing, especially in India. Atorvastatin is clear winner here. It's the most commonly prescribed statin, widely used for primary prevention with doses ranging from 10 to 80 mg once daily. Rosuvastatin more potent, longer acting, and importantly safer in terms of CYP3A4 drug interactions. A great choice when you need high efficacy and fewer interactions. Simvastatin still used, but be cautious at higher doses due to increased myopathy risk. Pitavastatin less commonly used but has minimal CYP3A4 metabolism, making it useful in selected patients. And fluvastatin metabolized via a different pathway, CYP2C9, so it can be considered when CYP3A4 interactions are a concern. So, in practice, choosing a statin is not just about the potency, but it's about the patient profile, comorbidities, and drug interactions. And that's what separates rote learning from medical clinical decision making. Let's wrap up this with a rapid 60-second revision. Statins block the HMG-CoA pathway, reducing not just cholesterol but also coenzyme Q10. This leads to mitochondrial dysfunction and ultimately myopathy. Clinically, it ranges from myalgia to myositis to rhabdomyolysis and even IMNM. Remember, the safer options are pravastatin and rosuvastatin when the drug interactions are a concern, and the absolute contraindications active liver disease, pregnancy, and breastfeeding. And never forget the most dangerous combination statin plus gemfibrozil, higher risk of rhabdomyolysis. If you keep these core concepts clear, you are just ready for your exams. You are ready for the real clinical practice. Thank you for watching. If you found this video helpful, don't forget to like, share, and subscribe our channel. See you in the next session.